Okay, welcome everybody. Welcome to the board meeting of Public Health Wales. Croeso, croeso gyfarfod board iechyd cyhoeddus Cymru. Mae'n braf ac gweld i chi yma heddiw. Diolch am ymuno i heddiw ffordd o braf, ond gyfnod gweithog yn Caerdydd. Good morning everybody and welcome to the board meeting today. The weather it's dry, but not quite the lovely sunny weather that we've had, but it's very nice to see you all here today. And just for people to note that this meeting is in person and online. It's being live streamed. So that being the case, we have members of the public attending, so people can speak their name before they respond and say what their role is, because this time when they speak today will be really helpful. The meeting's being recorded for by Microsoft Teams for the purpose of ensuring an accurate record of the minutes, and the recording will be stored until the minutes are confirmed at the next meeting, after which it will be deleted, just for people to know. We've had some apologies for absence from Hugh David, who is the new local authority representative non-executive director, recently appointed. I would be doing a welcome to him, but unfortunately he had another engagement. He's only just joined us and he can't be here today. And we've got Kate who's attending online. And apart from that, I don't think we've received any other apologies from them. Brilliant. We have a couple of visitors in the room, Sharon, Shika and Bethan from Screening Services. So they will be joining us for an item soon. So very warm welcome to you, and it's lovely to see you here today. Okay, if we move on to, are there any declarations of interest, please, for items that are on the agenda today?
I just flag a general declaration of interest on behalf of anybody in the room who's subject to the travel policy, which is here for approval for 5.4.
Thank you. Any other declarations? I've not seen any. So next item on the agenda, or first item on our agenda, is our screening services patient story. And then I'm going to allow you to formally introduce your team and their presentation. Thank you.
Oh, diolch. Mae'n nhw dwi Rhanwyddwr cenedlaethol gwasanaethau diogelu iechyd a strwythur. Mae'n co-lead director for health protection and screening services. And it is a great pleasure to welcome Sharon, Shika and Bethan to give a presentation around screening services. We interface with people in Wales across the right course by offering prevention interventions to identify disease at an early stage and offer early treatment with the expectation of better outcomes. So the team does a fantastic job across the 7 screening services that we provide across Wales, and we coordinate an 8th around antenatal screening. So it's a huge endeavour, and I know that as part of that, there's continued refinement of the service delivery model from patient feedback and also service user engagement. And this is an opportunity to just share some of the high-level thinking about the approaches, and the duty of quality has really helped us drive the thinking by a systematic approach through the 6 domains and the 6 enabling functions. So the team is going to kind of lead us through that story and journey. So I'm going to hand straight over to you.
Very much. So we've got patient. Fabulous. Okay, thank you. Thank you very, very much. That's really great. There's no doubt now we have a massive reach into our population, often across our population in Wales. So this is just a timeline from really, it's before you're born in terms of antenatal, and we're making you an offer through screening throughout your life, both depending on your gender and your age. So that's just showing you the breadth in numbers, but shy of about 1 million invitations, which is about our population of Wales each year. But what we wanted to talk to you here is about the approach to quality. And we just wanted to give you examples, things that you wouldn't necessarily see through the performance metrics or the detail, but it's really important for us in terms of the learning from different stakeholders and participants in terms of how we develop the service. So they are examples. We could probably do another set of presentations with you, those different examples. So they're just examples coming through, and they're purposely positive ones really in terms of examples. So Sheikha's just going to talk to you about the sort of duty of quality in the next slide.
Fab, thank you. So I know you'll be familiar with the duty of quality in itself and the aims of that around improving the quality of health services, helping people in Wales have more years of good health. And it's really explicit in there about a duty to listen to people and patients and not just listen to them. That's on that we find. So rather than going through the duty, I'll just go through some bits that have really stood out to us in screening. One of the key bits that really stands out in the duty is around how it applies to everything we do in the NHS and Wales. So therefore, everything that we do in screening division, it's not just about that point where we have the interaction with the service users. It's actually the whole pathway and services that we provide to professionals, and also services we provide to each other and how we interact with the rest of the organisation as well. You'll be familiar probably with the graphic that sits around it, and Meng mentioned again the 6 domains of quality on the inside. So the service that we aspire to deliver being safe, timely, effective, efficient, equitable and person-centred, but also around the outside ring of that thing, we have the enablers. So these are things that we need to have in place in order to deliver the inside. And Meng's heard me say this before, but when we first saw this, it was like, okay, there's more stuff that we need to do. There's a framework, there's a reporting element that sits alongside this. But actually, we had a real penny drop moment within screening when we looked at this framework and thought, actually, this is a really clear framework that sets out a really clear way for us thinking about the things that we really want to do. So the driver of this is actually our core value within screening, is delivering these excellent services. And this is a helpful way of us setting it out. So when we're doing the self-assessments and the reporting that we need to do, we make sure we're doing that in a meaningful way that helps us improve how we're delivering. I've probably said quality about 15 times already, and what we haven't talked about is what it is we mean by quality. And within the duty of quality, there's a really useful definition that they set out, and also they have definitions of each of the 6 domains of quality as well. And within Public Health Wales, as part of the clinical governance framework, we set out what we mean by each of those domains of quality too. So within screening, we took that a step further and did some collaborative work with people who work within the division to try and tease out what it is that we mean by each of these. So as an example, when we say we deliver a safe service, what does that really mean to us? And this was a really great piece of work. And when we finished writing it out, we put it through plain English and did some engagement to make sure that the way we put it across was really meaningful for people. And we've shared this with staff through team meeting, through presentations, and we've also developed these posters that we put up around our estate. So when we're delivering the services that we want to be delivered, we can be really clear on what we're bringing it back to is these excellent services and what that means. And you'll be familiar with the strategic objective around delivering excellent services, and excellence and quality, they're all really closely intertwined. And so we've had lots of conversations about how this is all just a pathway that's joined up around what are we delivering now, what do we want to deliver at the point of, I think it's 2035, isn't it? We say we're going through, and all of the route map on that way. And one of the things that we're working on at the moment is delivery of a quality management system. So the diagram there sets out that there's 4 elements to that. There's quality planning, which again is something we do. There's the quality control stuff, and we'll go into some examples around that real time, keeping an eye on how we're delivering, what we're delivering against our standards, and quality improvement, and also the quality assurance piece around this. So putting that together into a quality management system is putting together stuff that we already do, but also putting it together in that structured way has really helped us highlight if there's any gaps or any things that we need to make sure we document more structured. In terms of structures, one of the things that we've put together in screening divisions since the inception of the duty of quality is a quality group, where we have people from each of the programs, and teams within screening. We come together to specifically talk through elements of quality. We've got a rolling programme of going through the different domains so that we can look again whether we're talking about the same thing, and also make sure that we share learning and share how we can help each other to make sure that they're the most effective they can be. We've also worked with Claire's team at Enquig to try and pull together things like complaints, compliments, incidents, so that make sure we can triangulate that all together. So we're getting a rounded picture of what's going on. And again, managing things and sharing the learning. with STEEP right at the heart of everything that we're going to do. And one of the things, I guess, about STEEP that we've had discussions on room screening is potentially adding an extra S to that around sustainability as one of our underpinning principles. So we also have a culture action plan within the division, which I'm not going to go into today, but one of the key things around that is around celebrating success. So as we go through these next slides, we're going to talk about what each domain means to us, but also sharing some great examples that, as Sharon said at the start, might not be things that you'd seen here.
Okay, fab. So just some examples. So one of them under the quality bit of safe was the work that I brought to you before about the HMW. It undertook an inspection against the IRMA regulations, and we had back in August they went to North Wales and we had an immediate action plan, and you'd be very familiar with this because we brought this work through. We addressed those, and HMW were content with the work that we did. They came to Swansea in April and then took another inspection, and it was a very different experience. The team inspectors were thrilled with the visit, actually, because we had taken on board so much of their comments, and they had just sent us a formal report, and it's really positive. The verbal feedback on the day was they were really impressed with the staff. They were keen to improve the staff, and it was a pleasure for them to inspect. And the report has got lots of positives and notable improvements on it. So that was a very uncomfortable place for us. You know the work that we did to do that, but actually the April inspection was a really different experience. And they were, you know, the reports and the procedures they thought were really well written and great examples. So another example under safe, which is kind of under the bonnet of the work that we do. So it seems very easy to say we will invite everybody in Wales, age, gender specific. And we're really the only service in Wales that will proactively offer to that volume of the population. But the detail that goes into making sure the demographics is correct is really complex. And we've been drawing from a feed, which is the master patient index feed, which is there in health boards, and everybody had that feed. It's got telephone information on it, but there were errors in it because we were concerned that those errors would give us incorrect information and potential data breaches. So we've worked really closely with the digital team, with Ian's team and DHW to change that feed to the Welsh demographic system, and that's actually going to give us much more reliable information, and will stop our staff having to do all the fail-safe work that they've been having to undertake to make sure that data is correct. So that's very much under the bonnet, but really, really key to our safe service.
So in terms of timeliness, the example we wanted to pull out was the newborn blood spot. So newborn blood spot programme have a fail-safe where they check to see whether eligible babies have had a sample card received back in the lab. Post-COVID, the fail-safe date was set at day 15. But since then, we've done lots of work based on things that we learned during COVID, but also things that forced our hand a little bit, I guess, so the postage strikes meant that we had to look at couriers and other ways of getting samples in. So the fail-safe days moved back from day 15, we brought it to day 13, we brought it to a day 11, and now we're hopeful soon to move it back to day 10, which will be really clinically impactful, because actually some of the conditions we screen for a newborn blood spot, if there's even just a delay in the day in diagnosis, it makes a difference. So this is something we're really proud of. And in terms of effectiveness, we've used the example of a targeted intervention to non-responders around their first screening information. So working collaboratively with the National Health Protection Support Team, the Behavioural Science Team, we've put together a programme where there's a motivational interviewing approach to phoning up non-responders. And this has only been a pilot so far, so we've had a small amount of people that come through. But you'll see from the graph there, the proportion of people that we have managed to change from being non-responders to actually turning up to appointments. This has been really impactful. And actually already we've detected some aneurysms within that group. And for the numbers that we've seen, we wouldn't have expected to see as many aneurysms as we got, because we know that the people who don't turn up for screening tend to be in the demographic that actually might be more likely to benefit from turning up to screening. So this is real effective and efficient use of that resource.
So I'm going to talk a little bit about some of our efficiency elements that we've been looking at. So one we want to just pull out because it gives a really good example of how we're trying to use the best use of our resources. Our most valuable resource we have is our staff and their time. and listening to our staff about the processes that they do on a day-to-day basis and what changes they could make as part of that quality improvement process. So thinking from a more lean perspective. So an example of this would be our DESU staff, our diabetic eye screening staff, just thinking about where we position our equipment so that it makes the checking in and checking out process much more streamlined for them, which means they can get out to clinics quickly and more efficiently. And not only does that help them work in a more efficient way, but actually helps our staff to know that we're listening to them, we value their contributions and what they think will make a difference, and we're actually making those changes. When we're thinking about efficiency from a patient or participant person perspective, we want to make sure that when we invite people for screening, that we invite them and we're able to deliver that service offer in that first opportunity, rather than having to bring people back, often what we term reducing avoidable repeats. So a really good example of this is around the implementation of our new cameras that we have within diabetic eye screening. So these new cameras are able to take more efficient, they're able to take better quality of images, which means we have a lower rate of inadequate images. And that first graph just shows that drop off that we've seen in terms of our inadequate rates, which means we don't have to recall back into the service. Similarly, thinking from a bowel screening perspective, what we know and what we've tried to take some learning on, again, from our behavioural science colleagues, is thinking about what can be some of the challenges that people face in terms of responding to their invitations. And one thing we see is around them not responding in the right time frame or not putting the date. It sounds really simple, but these really straightforward things that people don't necessarily do. But by putting that information either within the letter or within the envelope, that's really helped to reduce the avoidable repeats. We're getting those samples in the first time, they can be processed the first time, and we can get those results out to participants. We talk about being efficient and we talk about being effective, but equity is really at the heart of what we want to be delivering. We have a really clear screening equity strategy that's been in place for a couple of years around making sure that we're providing that equitable opportunity, equitable access to all of our participants so they can take up that offer. We know that for many people, we need to be providing more targeted, more bespoke information that really responds to the barriers that they may be facing and helps to address some of their concerns. So thinking specifically about our carers, our screening engagement team, working with them, understanding what challenges for them, but also for the people they support, and developing those bespoke resources which are now available. We're looking at this sort of from a community's perspective, but also thinking at this also from our individual programmes. And bowel screening have really taken this forward. They're demonstrating the importance of equity by the optimisation of the bowel screening programme, which you probably will be aware of, around reducing that age by which we invite participants. But we know that we're not having an equitable uptake across all of our bowel screening of all of the people who were invited. So just in March this year, had a really successful bowel screening Equity Day here in CQ2, where we asked our third sector organisations, our colleagues within health boards, to come together to really think about the specific challenges. Brilliant support from the I&I Hub in terms of holding workshops in the afternoon, so we could really look at developing a bowel-specific programme of work to help to support equity. So we're talking to our health board colleagues, we're talking to our third sector organisations, but the most important people we need to be talking to are our participants, and thinking from a person-centred approach. So we're using lots of opportunities, different ways that our service users can provide us with feedback and then acting on it. So both from the positive perspective, feeding that back to our staff, but also thinking about areas for improvement. And another example, working again with our engagement team colleagues to think about text message reminders following appointments, so we can use that as an opportunity. That's been really successful in bringing a huge amount of new data in terms of what our participants want and need, that we can then make those adjustments.
Fab. And then I think that's the sort of the steep aspect of it, and some examples, and I think we could give you probably other examples in that field. But just going back to the quality labels going forward, that's something we're also really mindful on. So leadership and line managers are really engaged and really grateful for the leadership management training that's offered for Public Health Wales. We're really keen on growing our own, so we've got quite a few pathways for the staff. So we've had a consultant biochemist qualified recently, which is fantastic. Our consultant radiographers are key in our breast screening programme. Sheikha mentioned the culture action plan that's been developed with the staff. And DESI, for example, developed their culture club, which I think is a fabulous name. We've established, again, Sheikha's established lunch and learn sessions, which is fab because staff are coming together at lunch and just learning about a topic that's key for them. Information is absolutely key, and we could talk a lot about information, but we've done some key bits around the data exchange with prison. We've worked with the NHS exec about the bowel screening tracking system, which gives us much more visibility around bowel screening route for bowel cancer. Learning improvement research. Screenio is a research collaboration with Cardiff University, again focused on increasing uptake, reducing inequities, and we've got some key research grants with CR UK, for example, but I'm going to come and talk to Crick in June, so I'll go into more in there. And we do take a whole systems approach. We've got lots of examples where we're part of the whole system in Wales. So the implementation of MRI pathway for women at high risk. We're working now on about symptomatic fit testing, which came up in the recent MAG report. And that's a pathway we offer. We need to optimise that for Wales to get the benefit out of it. And obviously cervical screening and sexual health work really closely. And again, that's just some examples around those higher enablers aspects.
So we've talked about the importance of service user experience and the participant voice, learning from service users. But one of the things that we haven't mentioned yet, I guess, is making use of the service user voice to encourage participation within screening. And this is something that we've got back when we've engaged with communities about how the message lands better if it comes from people that they identify with. And as well as just using them, we've tried to be a bit creative with what we've got as well. I'm going to hope that this works.
We are the Cherokee Male Choir.
And we stand together to remind you to take your
Bowel screening test
when it comes.
It will save your life.
My Left Breast by Jenny Thomas. A few years ago, I turned 50. Received a dreaded letter. I didn't want to go, but thought I had better. The moral of this story is, if I hadn't been quite brave, you might not be reading this now. You could be standing at my grave.
I was told that I had a cancer of the colon, which was a great shock because I wasn't expecting. This was, I think, in September, and I actually went into hospital in November. I cannot praise the staff enough in the Royal Went. They were absolutely fantastic. And in particular, I've got to praise the colonoscopy nurses because they were there for me. They answered every question, and it made my feelings about it a lot better.
This is a story that we used for the 20th anniversary of newborn hearing screening Wales. It's a case study of a young boy who had hearing loss diagnosed at newborn hearing screening, and because of that early intervention, his family were able to get all the support that they needed, and he's now in mainstream school. He had cochlear implant fitted at the exact optimum time before age 1, and now he wanted to be on the West End.
We are the Cherokee Male
Sorry.
Choir.
And we stand together.
So the next story is a case study from Breast Test Wales, where we used some service user experience as part of a social media campaign to encourage younger women to take part in breast screening. And we heard back that one of the things that was a barrier was that people feeling scared about it. So this was a compliment that particularly talked about being reassured. So we used that. Oh no, sorry, I'm clicking in the wrong place. Do you know what to do?
We are
A lot better.
Okay, there we go. So the next story is about a really impactful AAA participant who didn't want to come to a screening, but did in the end and had a very, very large aneurysm diagnosed and ended up in hospital within
We use
5
an
days.
instrument called a speculum, which is this. So we insert the speculum and open it up like this, and we'll be able then to see your cervix. And then we place it here and we take that sample then.
I expected it to be a long procedure. I expected it to be quite painful. That was a tickle, if anything. I know everyone's different, but that was over in a matter of minutes.
over 50. It's time to have a simple test. It's just a plan. Our screening's easy. It saves lives too.
It is absolutely brilliant, that video. Thank you so much. And, you know, I absolutely, your passion for the quality of the service really shines through. It's a really impressive presentation, and I'm sure that you'll be very happy to share the slide and the videos and read all of the comments themselves. I think I'm sure everybody would be really pleased to see that. Have people got questions? Are there any questions?
I have comments to comment. I mean, just to echo what Pippa says, thank you so much. You know, it's real life-saving stuff. And it's at the heart of what we're about. And thank you for all of your leadership on it. I think that's a great montage. It'd be great to have it on the internet and the website if we don't for our staff, together with the slide pack. I think that it just brings it together and really focuses the emphasis on quality. Just a couple of things. Thank you all for all of the leadership around the HIW. That E slips in, doesn't it? HIW and Sharon, you know, there was such a lot of work that you and Dee and Sheikha that I'm sure were involved in and May. So it's great to have quite rapid feedback then of implementation with the April inspection. As much as we were a big challenge with the timeline, it was actually really good, and I think the proof's in the pudding. So a big thank you for that. I was at Kimberley House, one of our screening centres in Clinician about 3 weeks ago, and they told me the story of the protection support team, which is based in Cardiff Council, set up during COVID, doing a callback, and picked up a gentleman who subsequently had 65 centimetres of aneurysm. And that's life-saving, you know. It's great for them to be involved in making such a difference like that. So I just wanted to say, a huge thanks. You know, we have reports around screening and we talk about it, but it's life-saving. And I think that montage just shows it so clearly, doesn't it? And kudos to the person who helped to be filmed. So yeah, just say that. Yeah, no, it is absolutely brilliant. Kate, I think you want to come in.
Yeah, thanks. I'm just checking. Can everyone hear me?
Yes, we can hear you.
Yeah, excellent. Just really want to echo what has been said to a certain extent. A really exciting progress that's made. It was just a sort of, not so much a question, but just a check-in. There's been some fabulous work that was done by Improvement Cymru over the last few years around sort of engagement and having the voice of the citizen heard in parts of the medical processing system. And I just wondered whether we'd tapped into that resource yet. So, for example, there's a lot of fabulous bits of work that organisations like People First have done in partnership with them around things like health checks and things. So I know a lot of it gets joined up, but I suppose it's that if we've got something that's already in the system and we can use it and we can bring it in, then why not? It's just to build on all the excellent stuff that's already in that video. And I didn't mind watching the Treorchy male voice choir 3 times there. I thought they were brilliant. So it's just an observation. There's an awful lot of really positive stuff in there. And also, I'm not sure if you've had a conversation yet with the Paul Ridd Foundation, but an awful lot of what they've done in terms of having particularly people with a learning disability in spaces talking to people about what works for them is brilliant. And you may well have done, but just excellent work and just some extra thoughts on how we can build on it, really.
So, Kate, it's Bethan here in the room, just to say, yeah, absolutely working with Improvement Cymru, particularly around there is about building our evidence around screening uptake for people with learning disabilities specifically. So looking to try and do a first sort of work around what that could look like. So we've got a better understanding of the scale of the problem, and then working particularly actually with Betsy at the moment around the work that they're doing around animal health checks and how we can link in with that and what the screening offer could be as part of that process. But yeah, it's absolutely, we can't do all of this together. We can help to provide the data and provide that understanding, but it's really having that and those insights from people, you know, more involved directly with the participants and how we can help to support those. And that will then feed into the resources that we can then provide, and it feeds into the development of our learning disability action plan, which fits underneath our equity action plan.
Diolch Cadeirydd. Dwi'n mynd i cyfarfod y cynnig laeth o gyda chys. Dwi'n mynd i National Director of Health and Wellbeing. just really interested in the screening stuff. I know that Ben and I have conversations about diabetic eye screening. An invitation to you, we've recruited a panel of people living with diabetes who are helping us work through a range of things. So things like measures to improve, pathway measures to improve take-up. And one of the things about diabetic eye screening is it can be quite scary for people, can be a bit of a problem. What we'd really like to do is invite you to work with the Tackling Diabetes Together team, and perhaps to kind of work with some of our people with lived experience to look at how we make it better for them.
Thank you. So I have the lead for diabetic eye screening. So yeah, that'd be brilliant to be able to connect in. So connecting with Fiona within the TDT programme already, thinking about particularly the My Desmond app and thinking about how it currently doesn't have anything about eye screening on there. So thinking about how we can have more visual ways that people can see what the process involved, building on some of the sort of development we've done around pathway videos for breast screening, and that's been really responding to some of those anxieties. What does it actually look like? What will this mean for me when I go in? So again, thinking about how we can replicate some of that work with eye screening as well.
Yeah, you're both ahead of me. That's great.
Anybody else got any comments or questions? I really want to thank you. I mean, we're talking about you said 7 different types of screening. 1 million people is a third, almost a third of the Welsh population are coming through our system, and I think it's really excellent that you're thinking about the journey that those 1 million people are taking in order to deliver the best service and the best quality of service. So, and I know it's not just the 3 of you, there'll be a wider team as well. So I think, you know, that's something really to pass on thanks to the wider team, because there's an awful lot of people involved in this, and it's a big part of the work that we do makes a big difference in people's lives. So thank you. Thank you for the presentation. I have one final question, and it's really around the video that you've produced and where we can share that more widely, and whether or not we can get the Treorchy Mail Voice Choir, you know, to on live TV somewhere, you know, doing an advert or something, because I think that things like that are really impactful. So just a little bit of thoughts about how can we share this and where can we share this, I think would be really excellent, rather than it just being for us.
Yeah, I'm just thinking every month, as everybody painfully knows, we submit 2 positive things into our document as NHS conversations. So it would be great whilst the video, if you're happy for me to do that, then it's a couple paragraphs, because I think that's probably the most interesting thing that they'll ever read. So obviously with our content exempt from that.
Big thanks to Con for putting that montage together. Yeah. And one of the things that's I don't know you've seen on our page, there's a news story about the bowel screening team walking at Penabowel, which actually, if it come up, we just probably included that. And that's a really strong story, just you know, for that team to have supported. So yeah, lots of activity.
That's brilliant. And I think a presentation like yours really gives the board assurance that we're delivering services to the quality and the standard that we would really like, and within a framework, and actually triangulating as well all of the work that we do, not just against our own measures of quality, but also, you know, that feedback from patients. So I just wanted to say thank you very much.
Thank you all. Apologies if that tune's in my head.
We need an equivalent for over 65s. Right now.
You're working on
Yeah.
You walked into that
Okay, everybody, we're all happy. We'll move on to next item on the agenda, which Tracy is your chief exec report.
As far as our power, Tracy Cooper, and it's quite a long chief exec report this month, so apologies to add to the digital burden for people to read, but I think it just shows the breadth of activities happening. And I had to select these out of the very large list that was coming through. So I'll take us around and just maybe highlight a couple of points and bring some colleagues in. And people you may want to add to the first item. We had a really good meeting with the Cabinet Secretary and the Minister for Mental Health and Wellbeing. Jim and Ming joined us for it, covered a lot of areas, but a really open and constructive meeting. I don't know if you want to add anything.
Oh no, I think it's broadly what I would say as well. Is I think there's a real understanding actually from the Cabinet Secretary of the work that we do and the importance of the work that we do, and he was very interested in the report that we had.
So yeah, that was great. And just moving on to highlight item 3, and I'll bring Samina in a second. We, as colleagues will know, we work very closely with Welsh Government colleagues to support the memorandum of understanding they have with the World Health Organization. And the particular focus of that and our WHO collaborating centre that Samina leads is around the wellbeing economy, which basically positions health, the societal health, at the heart of fiscal and economic stability for a nation. So we've been doing a lot on that. We were delighted to support WHO policy dialogue on wellbeing economy that Welsh Government hosted Audit. But Samina, if you want to say something.
Thank you, Tracy. Sorry, Samina is our National Director for Policy and International Health. So as Tracy mentioned, it places the wellbeing economy places health at the centre of economy, of economic regeneration, of a healthy society. And the key thing about it is that it really helps drive us forward in terms of Future Generations Act. The event brought together 4 nations, and they're known as leading nations, so Wales, Scotland, Finland and Iceland. We were lucky enough to have ministers, senior officials, public health officials, and it took months and months of planning and hard work. So a huge thanks to the team who did that, and also a huge thanks to everybody who participated. So many here were at the event, and it really positively received. So lots of good feedback. I think there was a lot of positive learning there and commitment to action on many levels. So ministerial, but also on a practical level as well.
Thank you. And Pippa and Jim, Pippa was there the whole time and Jim joined us on Thursday as well. So it was really, it was great. Showcase of Wales as well. It was.
And I think for me as well, it was really excellent that at the end of it, there was a commitment to actually do something. So it wasn't just a question of people getting together and saying what's going on in their country, in Iceland, say, or Finland, compared to what we're doing. But then there was positive action to come out of it, and there will be further meetings, and I think that was really important.
Yeah, absolutely. And just to do a nod to some of the great events that our teams have been running, the International TB Day, the Nursing Midwifery Conference as well. It's just a great opportunity to bring our people together, and thanks to Meg and the team and Claire and the team for leading those. And when obviously the TB Days, you saw, we talked about it earlier, lots of from coverage for the media, and Tabitha, our lead, was superb in really pushing the awareness around. And then the really quite a seminal framework report on prevention-based health and care. I don't know, Jim, if you wanted to say something on that.
Thank you. Yeah, as Tracy says, this is the first in a series of interventions that are aimed at kind of putting prevention at the heart of health and social care. We're going to have to do more work on social care because they've got some stuff going on, but they're really keen. And thanks, Tracy, for linking us with Social Care Wales. The framework was launched last couple of weeks with quite a lot of people input from the system. It was co-produced with the system, and it seeks to actually make it easy for clinicians to identify what things need to be done and the populations for them, identify the interventions, and then do it. And it's actually gone out to community councils, to a range of bodies. There's a series of case studies that have just been published. If you haven't got it, just drop me a message and I'll send you a copy of it. The steering group is ongoing from people around the system. So what I'm really most pleased about with this is actually being produced with the system. Of course, I should say it carries it forward from Tracy, which is what I'm really most pleased about. but it's a very good thing, so I encourage you to read it.
Thank you, Jim, and then thank you. A couple of final points. Samina, really big congratulations to Samina, invited to be part of the Learning Society of Wales, which is a real honour. And yeah, absolutely wonderful. I've been practicing my curtsy every time I catch up with Samina. So really huge congratulations to Samina. It's so very well deserved. And then just one point on the COVID inquiry. Colleagues will be aware that Dr. Robin Howe, who is our director for our infection service, gave evidence earlier this week for Module 7, which is test, trace, isolate, on behalf of Public Health Wales. And Robin did himself justice. He came in extremely professionally, open, and I thought he conducted himself in an exemplary way, and put forward the position of the organisation in a really sensible and fair way. So a very big thanks to Robin and to all of our inquiry team to support him, and a number of colleagues, including Meg, who've been supporting in the background. And then final point that I didn't put on here, apology, just for noting, Pippa, that from the 1st of June, the NHS executive becomes the NHS Performance and Improvement, and so subsequent engagements and anything that we bring towards that name change will take effect. So I'm sure colleagues will join me in answering any questions.
Questions? I've got papers then, Sean. Kate?
Diolch, Pippa. Apologies, I forgot to introduce myself the first time I spoke. Kate Young, non-exec director. Couple of things. I was wondering, Tracy, the event with the Future Generations Commissioner, it was a positive event, but it was also sort of a bit like a throwdown of the gauntlet, because there's a challenge, isn't there, that we're behind in Wales in where we want to be in some ways. And we've got 10, 11 months before a Senedd election where, you know, the potential for us to be in, trying to find a diplomatic way of saying this, choppier waters, let's put it this way, in terms of political support around some of particularly things like the climate change and the green agenda. I was just wondering if you felt that there was more of a sense of urgency in the next sort of 10, 11 months to bed in some of the things that we've been working on around the future generation stuff, so that it's sort of almost further ingrained in some of the delivery plans across Welsh Government, so that in some ways it doesn't matter so much who takes on the hot seat in terms of leadership in the Senedd. So that was one question I had. And then just a suggestion around the prevention-based healthcare, which I think is excellent. And I'm really pleased we've tapped into Social Care Wales. But Jim, I think it would be useful if there could maybe be an opportunity to present that piece of work at the National Care and Support Office Advisory Group, which is that cross-cutting group that's looking at the whole action plan around social care and how prevention works. So outside of this meeting, if we think that's useful, I don't mind connecting you up to Bethan, who's the primary lead of that office. But yeah, it was just a thought around future gens, Tracy. It feels like we've got support right now, but I'm not sure none of us know what the horizon looks like, do we, from May onwards? So I was just wondering if we felt there was more of a sense of urgency to push some things forward.
Yeah, if I respond to Samina, I want to say some things as well. Yes, I mean, as you know, it's a strong focus for us around some work that Samina's leading, which is what we call the influencing and advocacy work in advance of the election. So obviously, being completely politically neutral, we would want the best public health embedded in any future programme of government, which means working back from that, we need to be influential in influencing manifestos that will then clearly began a new code for government. So I would say, Kate, yeah, everything we do, and it's easy to say, isn't it, but has to focus around the Wellbeing Future Generations Act. So the Best Buys work that we did in investing in a healthier Wales and prioritising prevention was all about 5 ways of working, long-term prevention. And so we've got a series of reports and products that will be issued, published, released over the coming months, including some very strong 4 or 5 key things that we've been discussing as board with that are easily transferable into a manifesto and a programme for government, and the interventions that have the most significant impact on improving outcomes patients and the public. So those, in my mind, are all absolutely at the heart of bedding something in for the longer term. I would say that we work really closely with Future Generations Commissioners Office. We share an appointment, we have a joint appointment. So we kind of work alongside them. We're doing a joint event at the Marketplace in the Senate with them in July as well, to push the prevention messages. And then finally, I'm sure Serena will want to add, Serena and I have the mental health process now, which joys of attending the Equality and Justice Committee. They do an inquiry on the post-legislative opportunities of the Wellbeing and Future Generations Act. So we're giving evidence at the beginning of July, and that is all about the potential for reviewing the legislation, what impact has it made, what are our thoughts. So there's an opportunity for us to push some of those messages. Samika, did you want to add?
Yeah, thank you, Tracy, and thank you, Kate. I think you're absolutely right, Kate. There is a sense of urgency, both in terms of the elections, because that provides us with an opportunity, but also in terms of population health needs. You know, there are some really key statistics that are going the wrong way. We know they are. So I think there are two things pushing us forward. And what I would also add to what Tracy has said is that the Future Generations Commissioners report and the Audit Wales report are really helpful for us. So the Commissioners report has got 50 recommendations to public bodies and to government, and a lot of them had our input. So we did support its development, and there are really good public health messages in there. So I think it's supportive of our agenda. I think also the Audit Wales report is very positive. We've had an audit of us as an organisation, and we've responded to that. And I think that was overall a very positive report. But the Audit Wales report that was published recently had 4 recommendations to government, and they are all about prevention and public health principles. And what it says is that you need prevention for sustainable services. And the other important thing about both of these reports is they are beyond political cycles. So they take us, beyond the Senate election and are really important levers for us. So thanks for the question, Kate. And I think absolutely really important need and an opportunity.
Oh. Thank you, Shambhala is non-exec director. I just wanted to congratulate you all, because when reading this, I felt really cheerful, actually. I thought, oh, that's good. There's so many things around at the moment. You turn on the radio, the television, or the newspaper, and you feel rather depressed. But actually, this is a really good story that's being told by this organisation. And it's not just in Wales, it's the international. Really, your stories here, or the points that we pulled out, and probably others, is working with the WHO, working with IAMFI, and working with Ireland. Really important that we're influencing outputs and experiences we get. So I just would encourage you to continue to do that, despite the pressures. I think it's really important. So thank you for all the work on that. And I was particularly pleased to see the MOU with the Arts Council. I think the demonstration screening team just showed how the interface between arts and health is a really important one that we need to remember and to keep up there. Because I think if you're working in an acute trust, you might not have much time to think about it with the other questions. So important work by public health awareness. So thank you to the team for all of that.
Thank you, Sean. And just picking up briefly on your point around Happiness and the MOU for the Arts Council, I think it would be really great if we could get some strong ties into Mello as well, so that Mello is directing people towards this, so that it's just a little bit more joined up, because that's something really important, isn't it, for people's mental health well-being.
And it may be worth inviting the chair of Chief Executive of the Arts Council maybe to a board meeting. Yeah,
fantastic. Yes, there aren't any other questions. I've just got a couple of comments. One of them is congratulations again to Sabina, and the prevention-based healthcare report I thought was absolutely excellent. I thought it was a really, really good report, and I wondered if it was worth sharing across government, because I think it contains so much useful information in a very digestible format that I think, that it's one of those things that I think for the wider political spectrum would be really helpful to them in informing future decisions. So I wondered if there's any way that we could share.
Yeah, we could pick it up with Judith and Charlotte, can't we, and see if they create that mechanism across, and or we ask, did we let them know that we're doing it? Yeah, we've done that. Good idea.
Wonderful. And we've got the reports from the directors as well. Has anybody got any more questions for Tracy or directors? I have one small question, and it's just my lack of knowledge. For men, I don't know what CL3 is.
So it's a category 3 laboratory.
Oh, right, okay. So that's just a category laboratory 3 then.
Yeah, that's
so, I just obviously hadn't come across it before, and so I thought it was the best.
Then just to elaborate, these laboratories that we need to ensure that there is seen capabilities in case there's an infection that's sort of high pathogenist.
And it might help us to have a glossary of these. Well, I managed to produce one in Nairobi, so very helpful. But yes, so it was one small thing that's not really a question, but I could have picked it up before. It's just that I forgot to mention it beforehand. If everybody's happy, I think Sean has absolutely reflected the assurance the board has taken from really excellent work that's going on at the moment, and I've seen lots of agreement around the table for that, so thank you. I think we can move on to the next item on the agenda. Ian, I'm going to pass over to you for the latest review.
Thank you very much, Ian Baldwin, Overrider, Will Data at DPDOL. So I'm Ian Bell, Director of Research Data and Digital. I'll start with a quick bit of follow-up from questions that the last board. So Caerphilly, and what do we know about Caerphilly? We're currently still learning more about Caerphilly, and we will get back to you once we know about why it was moving and bucking the trend on healthy life expectancy. On the dashboard itself, let's start with a bit of follow-up on healthy behaviours. And while most is flat, that spike in alcohol usage we commented on last time is still there. As we commented last time, the first step in what we're doing about it is the alcohol and drug needs assessment, which is, according to Jim this morning, and I very checked in, this is nearing completion now as we go, and Jim may want to say a few words about that as well. I mean, well, it is still just early, there is something there, and we do know mortality from alcohol usage with post-pandemic has been high, so there's something to look at there. The next area I wanted to just cover over briefly is looking at the health services. I think there's two things I'd like to highlight there. One of which is the vaccination uptake, which remains below target, and that's increasingly become a focus within Welsh Government. And so it certainly is noticed, not just for this, but other aspects as well. And how can we work with health boards in order to do it? Again, this may be something we want to pick up on as well. And then also at C. difficile, where again, the trends remain pretty problematic in health board land there. So again, there's a number of challenges in that space, all of which will require us working with health boards in order to do things that are not finally delivered. I'm not going to cover anything on the system ability to respond. We all know roughly where we're at in the wait times and the implications of it. Well-being trends again remain pretty flat around across the board. On the wider determinants though, there is one area I did want to pick out, which is the cost of living. And it's probably not a surprise, but we all know in April there were a number of increases in bills which impacted our households. And what you can see in the chart there is quite clearly public are picking up on that impact on their finances through it. And so what it is striking is that we are getting into another phase where the cost of living is already pressured and this is cumulative. Yeah. And so I will end there and I don't know, Jim May might want to pick up on 1 or 2 minutes.
I'm happy to pick up on the alcohol if you like. So we have done we are completing, and again, we've co-produced this with the system, a drugs and alcohol needs assessment that's nearing completion. On top of that, we've actually added alcohol modules to add to your life. There's an alcohol module in the diabetes apps that we're rolling out, and watch this space next week for more news on some of the diabetes work. I think we have several structural issues in Wales that we need to do, and the needs assessment is the first step. The guidance for area planning boards is now some 8 years old. And we've been working with directors of public health around service specification. In fact, we're advising 2 directors of public health on recommissioning the service. And I think alcohol and drugs needs a different response, not least because of the different ways in which it presents and the different issues. So we have started an internal cross-organisational group, which is actually looking at what more we can do. I think it is early days. I think there is a menu of things that we can do, but it's quite clear that Wales has an alcohol issue that is worse than the rest of the UK, both in terms of the severity and the frequency of alcohol, and is also worse than the rest of the UK in that presentation into liver disease and other diseases as well. So we are facing a significant challenge. We're at the early days of it. It is a driver in around 2 to 3% of hospital admissions in people at 45. That's a guess, by the way, that it's based on the data. So we do need to do more defining work, but it is increasing, and the amount of liver disease in the under 50s is increasing. And as someone whose liver has been affected by chemo in the past, you know, actually just getting information on keeping a healthy liver is not easy. So I think we've got a lot of work to do on this. So Ian, was that about?
Yeah, that's fine, and I might want to come.
Can I just ask you one? You mentioned they're separating alcohol and drugs. I think that's absolutely right. We always say drugs and alcohol, but on the drug scene, there's been all the changes around, you know, internet access, fentanyl, etc., which takes it in a different direction from alcohol. And so I would really encourage that separation. I'd be very interested to see how that analysis plays out.
I was just interested in, I think it's probably the data further on, that the smoking, we're going in the wrong direction, seems to be weighted towards the least deprived percentiles, whereas the alcohol seems to be with the more affluent percentiles. So there's something maybe around messaging, or and it's an interest to unpack, because you would expect that they might be similar, they both might be at least 5% increase, you know, the trend going upwards. Whereas I don't know if I read that right in the data, somewhere along the line that it was a flip.
Yes, I have some interesting data to share from our quality work on smoking later on during Angela talks about policy, if that's right. But I think what you've seen is, I would hypothesise that the minimum unit price has had an impact, and that the drug of choice, if you like, awful phrase, with more affluent people is turning into alcohol. Smoking has always been in decline among more affluent people, but less affluent people are continuing to smoke, and there's also the role of cultural norms. So there is still cheap alcohol, there is still a social pattern, you can see a social gradient in it, but it's quite clear that what we have to do is we have to adopt much more segmented and nuanced strategies in how we tackle alcohol and in how we tackle smoking and its impacts. That means different things at regulation as well. So the irony is minimum unit alcohol pricing has actually worked for some people, but is creating a problem in other populations. I would argue, happy to be called out on that, but what that means is we have to redouble our efforts, and I'll it updated the quality work on smoking cessation later. So am I making sense now?
Yeah, no, I was just interested in how that's playing out, because it was just that I noticed that there was a different kind of pattern and trend. I mean, smoking is also more expensive. It's not as though it's a cheap, easy habit, whereas with some street drugs, I think they sell very strong drugs for about £1. So you can see why there would be a split there. But smoking is not a cheap option.
No, and yeah, culturally it's ingrained in, ingrained in the family I came from. I think in 10 years' time, you will see a significant increase in more affluent people developing liver disease because of the current patterns. And that will be a crunch time.
I think on the alcohol, it's also worth bearing in mind, it's nearly always been the case that it has been most affluent with higher prevalence. However, when it comes to harm from alcohol abuse, it remains the most deprived community suffer the most harm. So we've got to look beyond just the prevalence and into the harms that needs to bring alcohol to get towards the true effect. So it may not be stark, although it looks stark, it can actually have as much harm in the most deprived communities for both.
Sorry, the sound dropped out there, but for a second, apologies. I just wanted to pick up on the cost of living and obviously people may have seen in the news today the article around the piece of work the Bevan Foundation and Policy and Practice have done, which is suggesting that with the current benefit reforms that are being proposed, Wales may see a £466 million cut to Welsh population income, and it would be about 6% of the population that would be impacted by that. So just noting the fact that Ian, in the sort of, the dashboard, as per usual, you see that sort of spike towards the beginning of the year where people get to go to a flurry to try and get hold of PIP, and I wonder if some of that is a little bit of a surge to get in before the doors close, or perception of the doors closing for the income and benefit. So if that plays out even vaguely at all as an actual fact of a percentage and loss of income, then that is going to see a significant detrimental impact, isn't it? Particularly, I would imagine, some of our most complex communities and a challenge around health and equality. So it's less of a question, I suppose, and more of an observation of the fact that it's a bit of evidence and data, isn't it? And working alongside the Bevan Foundation and the policy and practice team to kind of understand where that data has come from and what it reflects in different communities might be useful and helpful to us in targeting intervention going forward.
It's a really helpful point, Kate, and probably worth connecting it with Disability Rights Task Force as well. We're having very similar conversations about this at the moment. And
yeah,
I believe the Welsh Government are out for consultation on this. I can't remember the name of the document, but it's something around disability rights. And I believe that there is a question around that. So plainly, there is potential, isn't there, to have a negative impact, but we just don't know where that's going to land at the moment because nothing is signed, sealed, and delivered, as they say. So,
no.
I had just one question around, two questions. In fact, one of them is around CEDA and the numbers. We know across Wales that this is a continuing problem, but is this reflected internationally or UK or can you answer that?
Let me answer that, and I'd like to ask a question around the house as well. So on CDIF, we're not alone in seeing some big exceedances. In fact, it's got to a stage in England where England have declared an incident and put in place a way of tackling that. We've done a dynamic risk assessment of the situation in Wales and agreed with Welsh Government we wouldn't take the same approach. But there's ongoing work to tackle this, and you can see that some of these are quite reasonable long-term trends, and our heart team continue to advocate and support at a local level as well. I think it's agreeing with the health boards about what would be helpful for And one of the strategic ways of influencing is to be round the table in IQPT sessions when this is being discussed with health boards. And that's something that we are wanting to follow up with the Welsh Government about including that in the process. We actually raised it, I believe, at the CHEC meeting as well, so that people can offer that expertise which is absent in those constructs.
Yeah, that would help with consistency across Wales as well, wouldn't it? That's the thing, so otherwise we get different teams taking slightly different approaches, so that's really helpful, thank you Ben. You had a question? Sorry.
I had a comment about the alcohol reporting and wondered, there's a lot of work done about codifying alcohol related emissions loss, because that would then pick up a bit. And I just wondered if you report that by, the SRs, then I don't see it in the slide set, but I'm sure the data's there for us to do.
Generally needs it was what the infection prevention control campaign needs. And we agree with improvement plan to the improvement and to start really getting some things and also the challenge that we're taking in. So
that's really helpful, because I think it's the one job that we can do as Public Health Wales is bring some consistency to the wider population, as so rather than each having to feel like they're going it alone.
So at risk of probably, Claire Jenkins, interim non-executive director, vice chair. I wanted to have a similar discussion about immunisations, because again, that's been a pattern. It's not just a Welsh thing, it's a slow drop over a period of time. But I think for us as a board, the question is, are we still doing the right things to encourage uptake? Has there been a change in the data behind this which we wouldn't see? I mean, obviously we measure what's measured and what's measured is full completion rates, for example. So I'd be very interested in knowing is it that lots of people get halfway there and then give up, or is it that we've seen a growth in people who don't want to have any infections at all? And just some sort of an assurance that we are looking at that rate, just thinking, what is it that we do? Do we need to change what we do based on whatever lies below this?
Yeah, it's disappointing to see some of the rates going down, but also reassuring to see some of them are heading in an upward direction. And just to be clear, we are not responsible for delivering vaccination, but we have a responsibility for providing information that helps to create the action at a local level. I think we could do more around that. So our input has largely been on the governance arrangements across Wales, so the vaccination oversight structures that Welsh Government lead on, and NHS executive have a role in the delivery and performance management of this health boards. However, we've got an upcoming conversation next week with directors of public health, just across the services that we deliver, whether it's vaccination, HARP, and also our screening services, whether there's more information that our directors of public health would find useful to support the delivery of better outcomes for all our populations. So I'm looking forward to the output of that discussion, because I do think that if we get granular with the data and we can share at a very local level about the hotspots where the uptake's not as good, and we have that data, and it can only help with the local intervention. So I'm confident that we are trying to get to the bottom of this. Our team is doing the work about understanding what are the barriers. We don't think vaccination hesitancy is the issue, actually. People talk about fatigue, don't they? But when you've done the research, we don't think that's the case. So we are calibrating our approach to the winter campaign communications around this. And we've prepared a report that we will shortly send to Welsh Government for consideration as well about our approach to winter vaccination.
Sorry, can I just check on the vaccine scepticism in the light of the American experience at the moment? Because I think there's such a huge global change here, but I don't know whether your TPH has been a sort of pervasive influence in society in general. I just would raise it as an issue.
It is an issue, and we're very, very cited on the skepticism across the world. Know that the team is continuing to understand how that spills into our public understanding in Wales. Inevitably, it will have an effect. So part of our and part of our campaign is about busting the myths that are and also the untruths. So
yeah, just on vaccination numbers, a part of the advice that we've shared with government and been involved in a lot of winter planning meetings, as you put in the is that the variation in across practice is GP practices, and that where there are the recurrent patterns of that is that for health boards to actually be leaning in and engaging early with them on doing top-ups, or how is that engagement happening through the opportunity with third sector, etc. So data is really important in this, and it's all part of the challenging access to GP primary care data, which is all part of the discussion that we sorted as well. But it is literally looking at what's happening within your community areas and your primary care clusters, because that the magic happens locally, and that's where the engagement is. So what's the model happening? Are they being proactive? So there's a lot, I think, for us, there's primary care that's key, that may or may not be a factor. People being sceptical. It's just that the accessibility is just not convenient if you're trying to do two jobs and you've got kids, and it's the offer isn't accessible enough.
And that's a really good reminder. And I wondered whether there's any opportunity to include vaccination data in our primary care dashboard. It's something to consider, because I know dashboards are widely used at cluster level. Sure, that's somewhere back of range.
Great, thank you. I think there's only other one which isn't in the paper, and it's given that it's latest public health overview, then you might want to just briefly update the board on the crypto outbreak.
Yeah, so board will be aware in the media of an outbreak of cryptosporidiosis in an open farm that resulted in many cases having confirmed that crypto infection. I think to date there are 145 cases, and this relates to the nature of the farm and the practices that were in place at the time. But I'm pleased to say that the control measures that were implemented on the 29th of April were effective, and no cases with attributable contact after that event. So there's ongoing investigation of the cases and further learning around the incidents that the outbreak control team is conducting.
Thanks, Ben. If there are no more questions, I've not seen any more questions or comments around the table. I think it's really helpful to us. Thank you very much, and really assures the board of the work that's going on and the data that we're looking at in considering decisions and actions. So thank you very much, Ian, for that. We can move on to the next item on the agenda, which is the performance and finance review, Angela, for 24-25.
Thank you, Chair. Well, I'm Angela, the Executive Director of Operations Finance. So I need to say thank you much for saying that. So hopefully we'll have a chance to look at the detail in this report. It's a new report that we've developed this year. It gives a flavour of the performance across the whole of the year, rather than each month we bring the individual performance insight report. But this brings all of that together in one package. I think it's a really useful addition to our suite of reports. So what I was going to do was just say that actually what we've done as a performance team is just bring together in a cover paper that supports the insights report just some highlights that we want to draw the board's attention to. So we acknowledge where the performance levels have seen improvements, but also where we've experienced challenges. So we've tried to draw that out into the campaign as well. So if we go through each section, I sort of bring each exec director colleague in to add any complex in terms of the areas that we highlighted. I'll take the prerogative to just pick up the finance section first before coordinating. But just really pleased to sort of present a really strong performance across the year 24-25. I'm sure we're going through the audit process now. We're in week 4 of the audit. So the draft position as it stands is that we will report the revenue on spent 195,000. Hardly any issues have been brought to our attention. We meet weekly with the auditors, so that's going well. We've met the agency spent target and the PSP target, and really pleased to note that we are ranked number 1 across the entrance rails to some PSP deliveries.
Although we compared to
yeah, so from my perspective, I was just going to highlight that from a financial performance perspective for the year 24-25. Would anybody like to ask anything on the finance one through the rest of the board?
I've not seen any hands.
So Neil, if I turn to you for the governance and accountability section and the sickness, as that was one that we highlighted in the cabinet report, but you may want to add anything in terms of the other graphs and charts that we go through that section.
Yeah, diolch, Neil Lewis, Director of Development, and yeah, just to say a huge thanks to Andrew and the team. I think this kind of takes the board to a level in terms of steering this over that kind of annual basis. Just a couple of points I wanted to pick up, and this was kind of specifically some questions were asked by people at the previous meeting around sickness absence. So I just wanted to pick up around kind of anxiety, stress, depression, as colleagues are aware in terms of our levels in that space and across the NHS in Wales. It continues to be the main reason for sickness absence across public health Wales. As colleagues are aware, we do and continue to undertake significant amount of work in this space. One of the questions was asked at the previous board meeting was around our ability to get into a kind of deeper level around work-related or kind of non-work-related stress, anxiety. So within ESR, we've got some constraints as colleagues are aware. There is the ability for us to record in the system, however, not to mandate that. So the path that we're going to take them is really now to do some work with our managers across the system to really stress the importance of providing this level of data so that we can report on that. We do have some data in there, but not enough for me to be kind of say to you today with any kind of real detail of what it's sort of relatively meaningless in its kind of current format there. So what I can suggest, colleagues, if you are happy, is that we will take a more detailed report around sickness absence, especially around anxiety, stress, depression, for the next podcast meeting in July. And also, as part of that meeting, run through a number of the things that we were proposing to do to, one, improve data quality, but also to specifically make sure we can report that area moving forward with a significant amount of detail. There is some work that we will need to do in that space with managers, as you would expect, but my intention would be to use the July meeting to take that to Ofcom. So that was the kind of the main points that I wanted to raise, but if you have any questions on sickness absence or any of the areas and things in the report from a people perspective.
Yeah, I mean, personally, I said it, but I really appreciate this format before. I think it's so much better where we are. Specifically, a couple of questions actually, Neil, if you don't mind, on the section page 6, we've got the graph around the sickness absence by term. What do we mean by long term? Do we have the definition of the long term?
I should have that to hand that I haven't, but I will get it to you in terms of the split.
It's likely a catch question because
I think it's over 4 weeks, but I will just confirm.
That kind of falls into my catch question. Okay. I'm assuming it has to be less than 4 weeks, otherwise there's something wrong with the graph. If the numbers go down far too quickly,
And so in my head, I might be looking at it wrong. So my head was, are we at the same long term is too short? Feels very short, if it's like 2 weeks or something. So either, I might be wrong, but either there's something in the graph or there's something in the definition of long term that means they don't seem to make sense, particularly in the health and well-being section, I would say. But I may be wrong entirely on that, but just make the observation. And the one other thing I was going to say, actually, and call out, is particularly to note on the mandatory training and the appraisal, the difference between this year and last. Yeah, both the stability of it and the much improved position. I think it just should be called out. You can see in this report there across the year, just so much more positive.
Yeah, I will come back. We will look into the long-term piece and look at review what you said there. You can see that to jump off the page. We will look at that and come back to you just to check on that point. In terms of the improvements as well around appraisal compliance, I think it's fair to say really reinforces as well the power of the PodCom arrangement as well, because the work that took place during the committee in terms of us looking at that, we had Men's Directorate specifically a spotlight in that area, and the team came. We saw significant improvements as a result of that. We could see tail off a little bit. I know Meng is doing some work for the team in terms of looking to make improvements there, but I think I would certainly say the role of PodCom has played a key part in those improvements as well.
Congratulations to Kate on compliment. Yeah, 2 points. Periodically, as chief exec, as members of the exec team will have a corporate objective. So we have over last year, we had appraisals Statman. So our Statman dropped off last year because once we got there. So it's quite helpful. So every next term we've been doing ED&I, so there's something that we all focus on. So just it may be helpful also, Ange, that we put the numbers of people within corporate health wellbeing, because for some directorates we're talking a much smaller number of people, and for others we're talking about a much larger number of people. So, just thinking for kind of, NQUIC, Claire, if you have 2 people on long-term sick, that looks very different than if it's 2 people in health protection screening services. So we can kind of try and put the kind of ratio percentages.
We move on to the next part of the governance accountability section, which sits Claire in terms of what we think that we have on paper. So
yeah, so 2 areas just focus on, one around IG. So you'll note on the work that we do actively with myself and we have performance Manchester Live, which on a weekly basis, and we can start to see some of that in December time. So you can hopefully see that starting to really we've got control over that, but it's also helping us understand what's happening. There are also some really complex ones that come in. Those that have been competitive, so we do provide a lot of support. We are currently interviewing for 2 new IG marketing managers, which will slightly further effectiveness. Good performance around subject access requests as well, and again we're doing some mandatory training within IG. In terms of incidents, on page 16, actually say 2 duty account or incidents reported. I'm sorry, I haven't got ahead of today's meeting. Both of which were ventilated appropriately and followed the regulations around the duty handle. We will see that go up in future years as we now report on the road, but we will look back at it's for the answers. So we will expect to see that. The number of incidents over time is increasing, which is a good thing because we're encouraging healthy reporting culture. And closure rates are improving as well. We have started to see some real improvements in long waiting incidents being closed, but it's variable and we need to have the same control so we can bottom around everywhere. The only thing I just want to mention is around concerns. Generally really good performance around that, but they're very sort of numbers. So again, we're going to have one to go over and we get 2% compliance. But again, we've tightened up that process. We've had to simplify the QA process there. And we are doing a little bit of performance management where we've got services with handed complaints managers. They can do something to sit or we can't afford that. They want to be managed.
Questions?
Thank you. So if we move to section 2, this covers our service delivery. So in the cover paper, we've highlighted a few screening performance issues that we picked up and acknowledged those there. So I was just going to pass to Mel to pick up the areas, the cover paper, and any other comments you want to make.
Thank you, Angela. And it's good to see the kind of report over the year and the trends over the year. And you'll note that for several of the elements of delivery and screening programs, we're not where we want to be. So for Breast Test Wales, we've seen a persistent inability to provide the assessment clinics within 3 weeks of the screen. And that's been the case over the last 12 months. It's useful to remind ourselves, however, that Breast Test Wales recovered formally in July last year. So it's still very early days in trying to get the rest of the processes and systems streamlined in the most effective and efficient way. There have been some incidents over recent months that have continued to thwart our attempts to improve this indicator, which include the rollout of the PACS machines. So this is the monitors that are used for the digital archiving of images. So at the point when images are taken, they then need to be read. And there's usually a bit of a delay there. But if you can't read them because the monitors are not fit for purpose, then that adds to delay. So that actually caused a bit of additional delay. But the monitors were replaced very, very quickly over a weekend with staff coming in really to help. But inevitably that will have led to some backlog in the reading. The second thing that happened was around the recent review of the implementation of new equipment in Breast Test Wales that found some issues in terms of the mobile units deployed for Breast Test Wales. Most recently, there was a loss of service for one of the mobile units. Again, this meant there was some service disruption in our ability to invite women at the right time. But fortunately, we were able to divert some of the activity to the other assessment centres that we have in place. And I'm pleased to report that that unit is recommissioned and will be back in service early next week. So we are working through some of the other issues like long-term sickness absence in clinical staff that are an essential part of that assessment pathway to continue to mitigate this. But I hope the board will be assured to hear that I have asked the programme to consider and put in place an improvement plan so that we can do a more systematic review of the root causes of some of these practices across the 3 screening centres for Breast Test Wales. And I will be doing that working with our Assistant Director of Operations and also Director of Screening Services so that we can understand how we best bring the experience and skills around service delivery to make this the most efficient and effective service. In relation to diabetic eye screening, again, the indicator is not where we want it to be. And there is a Diabetes Transformation Programme Board established, which has access to funds to look at innovative ways of improving outcomes on diabetic eye screening, particularly around efficiency and timeliness. We did move to a low-risk pathway where people deemed at low risk would be screened at 2-yearly intervals rather than 1 year. So some of this reporting doesn't quite reflect that transition about timeliness of screening. So I think over the course of the next few months, we should be able to rectify that data. But I know the team is working on the transformation agenda, and one of the things that will help us deliver a more efficient service is the potential of not using eye drops. Now, the use of eye drops to dilate the pupils adds time to the process and the activity of screening. So if we don't need to dilate the pupils, then we can invite more people. clinic. And that will really help with some of the delays in inviting of participants. And this is going to be subject of a formal research evaluation so that we can understand the literature around this, because we don't want to be an unsafe service, because we want to assure ourselves that the quality of the images that we obtain without the dilated pupil is equivalent to one with dilated pupils. And then lastly, bowel cancer screening. Again, we're not where we need to be in terms of the 4-week waits for colonoscopy, which is the standard. We've not achieved it in any of the months in the last 12 months, and that position continues to deteriorate. So when you look at the figures in March this year, it's 8.4% were compliant with that 4-week wait target. This has been escalated within Public Health Wales, and we met with the team to understand the interventions we need to put in place. And Tracy, as Chief Exec, is committed to meeting with counterparts in health boards to address these concerns at a local level. We continue to have the local monitoring and contract arrangements because we commission this service from health boards, but we have now undertaken a very comprehensive review about the root causes for the delayed interventions at a local level, and we'll be sharing the data with health boards to help with the discussion. We've also escalated to the Welsh Government, and we'll be providing an update on our planned actions at our forthcoming January. So I hope that gives you an overview of the interventions we're putting in place to improve the position around 3 key screening programs that are not doing this. We should do. It's very helpful. Thank you.
Any questions or ideas?
Yeah, I mean, thank you for that. I mean, those are areas that obviously don't make the best reading when you look at the chart, so really helpful to have that. Only quite helpful at the right point in the future to see what the kind of trajectory of recovery looks like, so that we have an expectation and we can information against rather than would be helpful. Just one observation on the chart, which to me appears to be an anomaly in Wales report, is actually in the blood culture collective incubation SMI 4 hours. It's the measure is less than 4 hours. But compared to the others, we would have had a percentage number we hope to achieve. Just read the little what 100% all the time. Is that right?
Yeah, so I think we need to really look at how that metric is.
I think it's a presentation issue, just so that we're clear what we're measuring.
Because it's
that the other, we would have left the 4 hours in the left column. We'd have put, you know, what we want to achieve would be in that column. So just an observation. We should really, I mean, that's one of the reasons it's a really helpful format, because we want these things now and we can see the variance. Just an observation.
Jim, the only other point to the campaign going really our areas, and I know you're in that section too, so I didn't want to leave you out, but we were focused on management areas.
Neil, thank you. Thanks for that. I don't know less. Shall I just run through quickly and then to me? I'd like to highlight just 2 things in this. The first is the school approach to emotional and mental wellbeing. So this is a voluntary scheme. We cannot compel schools to sign up to it. As programs points out in some occasions. 100% of Welsh secondary schools are signed up. We are the only nation in Europe where 100% of schools have signed up to that. So that has been a huge effort by head teachers, by directors of education and local authorities, and by our teams. And I'd like to do a big shout out to them all on that one, and to our directors of public health. 98% of them are action planning, but the Secretary of State's accepted actually it's really 100%, because the 2 that aren't action planning have got blue plans. So, and you know, 80% of all our schools are action planning and 96% are signed up. So that's done. The next stage is we've been working with the Cabinet Secretary and Estin and Directors of Education to look at a healthy, mentally healthy whole school day. And so there is a multi-agency group looking at what we need to do on whole school day. we will also be revising the toolkit to make it easier for head teachers to work out what not to buy, what to buy. So I think we should celebrate the fact that we've achieved that, and it is good because it's been endless work. And then I'll turn to the more mixed picture of smoking, if I may. So you'll have seen on slide 61 that Ian presented that smoking rates stubbornly, they fluctuate, but they're really stable. And there are two real ways of getting those down. One is to really get people into referral to services, but that is not going to deliver it all. The other is the legislation and the regulation. So you'll know that we've been working on the legislation and the regulation and really supporting our government with that. But actually we've been doing some quality improvement work on our smoking cessation rates. So against the backdrop of smoking cessation rates declining and the number of referrals to services declining, we looked at the last 3 years. So, and we looked at the last 3 years just of our web referrals, coupled with a revamp to the Help Me Quit website. We've actually seen a 58% increase in referrals through that website over the past 3 years as a result of our social marketing work. We're going to write this up and present it to QSIC. That's actually a 34% website self-referrals against a target of 25% in London. So we set some targets and we've exceeded them. The conversion from referral to quit is around 20%, which compares favourably with the rest of the UK as to the rest of them. So I think I'm saying that just to show that Claire's influence on quality gets everywhere. But we've started applying it and actually learning how we can really target people, target demographics, and turn that into yield. And I'm hoping that the success of the social marketing in the website will actually enable the rest of the team to kind of work on other things, because the next thing we need to do is nurse, which is massively oversubscribed, but there remains a gap. If you look at pathways, there's a gap between referral and setting a quit date. There's a drop off on attrition between quit date and long-term quit. The same with nurse. So what we're doing is systematically going through all of these to up the yield so that we get the best yield possible. So the twin arms of regulation and referral, and of course the website's not the only source, will actually continue to give us yield, because we've got to do that if we are going to hit the 2035 ambition of a healthy life expectancy. So I just wanted the board to be assured that we're happy to provide more questions, answer any questions and give you more information. We just wanted you to be assured that we are looking systematically across our business in health and wellbeing at how we're meeting our targets.
Do we have any information about vaping and smoking? So this is just nicotine, just cigarettes.
Yes. So this is just tobacco smoking, and there's lots of information on vaping, and maybe the one thing you like is a more detailed presentation on it in terms of vaping.
Maybe we should pick that up in the future, and what we consider to be potential future harms as well.
And Helping Quit is looking at diversifying its offer into the vapors as well, so that will persist with getting renewal.
Yeah, so I think we should probably pick that up at some point. And I think the other thing that we need to consider is whether or not these are all the Help Me Quits are all people who have always been smokers, or whether we're losing some and gaining others, if you see what I mean. Because the numbers are quite, if it's whatever percentage of the population, are they all people who are lifelong smokers, or are some of the lifelong smokers stopping, or we're getting new starters? And I think some of that data might be helpful if we've got it.
Yeah, and I think we do have some of that data, and it's quite interesting looking at the social patterns. So there is no doubt that people are still initiating smoking in school, which is what Just B is trying to tackle. There is also no doubt that significant numbers of people coming to Wales to live smoke. The smoking rates in Poland, for example, the smoking rates in Ukraine, smoking rates in a number of nations, that's bringing in a higher rate. So what you've got is a rate that's remaining stubbornly the same. A lot of people entering the smoking market, some of them rejoining the smoking market, and some of them starting the smoking market. And it actually becomes quite difficult to tease out. But given this is the social reality of where we are, we could either choose to be defeated, I think as some places have, or we could say, no, we're actually going to drill into this and we're going to look at where the yield will come. And for you to be asking, I think that is the right question to be asking. It's really helpful.
So and it'd be really helpful, I think, to bring back to board in some way, so that we have a presentation that we focus on this, because it is a problem for society, isn't it, for long-term health. Did you want to bring in?
Just a couple of things. Actually, congratulations on getting signed up. I think that's great. I just want to put on the table sustainability and impact. And we've got them signed up. Can we show that having them signed up is going to make a difference in the long term? And that's the challenge, I think. So I'm sure you're looking at it, but it would be interesting to know where we get to on all of that. And I'm also interested in the whole concept of self-referral for help, the increased rates of self-referral for help to quit smoking, because you see it in other forms of the whole concept of use of social media, the whole concept of taking responsibility, and where that trend goes in general in your whole area of work. So maybe come back to that at another time, because I think it is, how do we then message online as much as that? Who do we message to? Which section of the market, so to speak, do we need to focus on there vis-a-vis outreach or contact, and how they then come back together again to get your overall outcome impact?
I think the answer is increasing segmentation of that population to target them in ways that will work. I mean, Ian's been challenging us to do more on digital. The kind of the web transformation program, I think, is a real opportunity, and I think you're right. In terms of impact, we're working on measure to a suite of indicators, hopefully not too many, some that are already collected to give us some measure of impacts in schools work. But yeah, these are the kind of, I really welcome more advice from you.
Thank you. I found it really interesting. Excellent work.
Samina, Ian, do you want to add anything for your sections?
Just a few things if I may share. So there's a lot in there, but it reflects about a year's worth of work. It's very narrative, but that is the nature of our work. The things I wanted to highlight, huge amount of activity and progress on climate and health, and that's across organisational piece. But this just brings to the fore some of the really good work, like climate surveillance, which Mainstream is leading on. Behavioural science came up earlier, and I was really pleased to hear it in terms of the screening services. And that's just a snapshot of what they do. So in the report, you'll see that they've had engagement with 2,000 people. So those are 2,000 people across different services, across the health sector and other partners. And they've got a thriving community of practice. So it kind of shows the reach that they're beginning to have. Two of the quick important things, HIA legislation, so health impact assessment. Our support unit is working with Welsh Government to develop the regulations, and we're also working with them to support the implementation. And that's going to have a huge impact for us as an organisation, but also all public bodies. So I think that's really important for us to keep an eye on. And finally, trauma-informed approach. So the team have done a fantastic job in supporting sectors across Wales to become trauma-informed. So we're talking housing, criminal justice, further education, and we're now working with the health sector. And it's a real accolade that the British and Irish Council selected them to showcase the work. So yeah, very happy to take questions.
Sorry, I hadn't realised we were doing questions in the moment. I just wanted to go back to the screening, if you don't mind, is that okay? Just obviously it's a major concern, the figures of screening. And I don't know, it looks more alarming than maybe it is, the 8%, you know, there's the target of 30%, it says 8%. So I'm assuming that's like a technicality in terms of the measurement rather than
we are that far off our target.
We are that far. So, you know, only 8% are compliant of the 4-week wait target. And just remind ourselves, this is wait times for bowel screening colonoscopy that we commissioned for the health boards. So there are some health board areas where the assessment centres are experiencing 14-week waits. That is not something we should accept. So that's why we're putting in place this escalation to try and improve the situation.
And the breast test is also quite far off target.
Yeah, so the breast test Wales is a 3-week wait for the assessment from the date of the mammography. And for the reasons I've explained earlier, when you take the mammogram, you have to wait for the images to be read. Once they're read, you're then invited or not invited to an assessment centre. So the longer you leave the reading interval, you're then getting into that 3-week time. Now, my understanding is that actually in reality, we're looking at 4 to 6 weeks. So the increase in wait times is not as significant, but nevertheless, we do want to keep in the 3 weeks.
I think that's what I was kind of trying to get at. Are we talking about like 2 days over target date? Or
No, we're talking weeks over, but not months.
And, you know, it's really reassuring to hear that they're talking about this implementation plan. And I think there's further paper on the agenda that in which there was kind of some kind of outlining of future training that's required in the organisation. So did that happen last year as well? Did that kind of review happen last year in which we flagged up our requests? So has that been happening year on year in which we flag up our training requirements and our, I guess, improvement requirements? Yeah, so I'm just trying to work out, are we clear about, you know, it's clear that you're trying to unpack all of this. The team's not big enough, but the team's not robust and big enough for the task at hand. Or are we just keeping coming up with these continuous like issues that are causing roadblocks, if you like? So the modifiers, more of vehicles. Is it more of an equipment issue? Are we talking about a team issue? Are we talking a combination of all? I know we have issues about improvements. Are we able to look at different kind of solutions to that recruitment problem? I'm just wondering. I know there's lots of things going on, but it just seems like in terms of us as a board, this is quite an alarming situation. So just, yeah, trying to figure out what's the resource in this area.
Maybe times it's a huge topic, I think, and one that then might not have all the answers at his fingertips. I wonder if it's something that we can bring back to the board, where we can have a discussion about whether or not this is a repeated pattern from year on year. Whether the recruitment and whether it's equipment, whether it's recruitment, whether these things are within our control or not within our control. Yeah. So perhaps we can have some kind of a briefing on that.
And also, really fundamentally, is it a resource issue?
So
is there enough resource in this area of the public health Wales in which I think that needs to be looked at?
I think they're really great questions, and maybe if you could come up with, because I don't know if anybody's written them all down right at the moment, but if you come up with those kind of 3 or 4 bullet points that you've just raised, and then we can bring it back and we can have a longer discussion, because I can see that we could end up talking about this for half an hour or something, you know, or more, about that kind of entirety of the resource and people and you know, equipment, etc., etc. Would that be helpful? Angela?
Yeah, I was just going to say as well that Beck and I are going to our IQPD, which is the end of June, which is not all about screening. So we've got to prepare for that. So it could be a good opportunity helpful to bring it all together in terms of what we need to take for IQPD. Could actually come back to board.
That would be really helpful, and then it gives us consistency as well around what's being presented to Welsh Government as well. So I think that would be really good. Is that okay?
You may have some very, very quick, like, I tell my space, it'll be very, very quick. And I have it.
Yeah, I think this is why I want to put in place a review and an improvement plan, because I do hear about all these very valid reasons. Some are expected, some not expected. So that we've got a systematic approach to just undertaking a diagnostic. Is it a resource? Now, I know it's a resource issue in terms of inability to recruit to key critical posts in North Wales. And I hear that. I just need to get to the detail. So I think if you allow me a bit of time to do that kind of more systematic review, looking at structures, processes, outcomes, take an evaluative approach to really do a deep diagnostic on what is it that we can then put in place to improve the position that we don't want to be in. Let's also be clear that this is one metric of many that we haven't reported, because the others are actually doing quite well. Yeah, so we shouldn't lose sight of some of the metrics underlying all our screening programs. But I can commit to providing the detail of that. But it will take us some time to prepare that overarching understanding of the problem.
Great, thank you, May.
So the last part of this report was on section 3, which is the strategy delivery. So the only thing I was going to say there was I think it's a really useful summary by the priority of the work that's happened in 24-25, and it's a bit of insight into 25-26 as well, which again shows like really want to add anything. And this is probably going to be part of our objective conversation next week.
Yeah, we have a jet meeting next week, so we just one last bit of sorry, that's Rebecca. I will share it obviously with all the boards and see it. No, I think just taking this red edge.
So hopefully that moves forward assurance of what we developed during those suite of training performance.
Well, it sparked a huge amount of conversation, so, and I think we can take assurance from the fact that there's been so much conversation. I've got Sean.
Just had a very quick one on the research. I thought Ian might pick it up and show me increased data. It's an income generating story there, which I think is really good. So I think Ian's still done a huge amount of good work in the research area. And identifying PHA document there as an area. So I think that was quite helpful to see. There's more money there, isn't there? Over twice as much this year as last year. So that's another good news.
We've got more people getting awards. There's more people getting the research awards and more money per award as well. And you get a detailed thing quick around it. I will say quick work on DHCW, although it's highlighted, it is only 3 of the milestones which directly relate to DHCW, and you're picking up on that. So each of them, some of them are for better reasons than others, shall we say, and leave it there. Yeah.
That's great, Angela, thank you. I mean, the structure of the report is excellent, and obviously it's bringing all of the really important metrics to the board, to the extent that people are looking at it and they're asking the right questions. So it's absolutely brilliant, very open and transparent. It's absolutely what we want. So thank you very much for that. I'm going to suggest that we all take lunch break now. And come back because we are running a little bit late, I'm afraid. We'll come back at 20 past, if that's okay.
report when the fund's there. It's the first one, obviously. So that it's early days in terms of some of the work, which is to bring to board's attention around the status of the anticipated allocations, the progress we made in our savings delivery, which is really great, or green savings, which has helped us then to reutilise the savings into some of the priority areas, which is all within the report, so something I highlight that.
Yeah, I think it's really impressive. And thank you, Director. That's operation. Yeah, thank you very much. Any final questions on this? And of course, month one is always very early days, but I think that we can, you know, as a board, we take assurance that we're heading in the right direction. Lots of discussion on the previous item, which is reflected in the report. So thank you very much. If we move on to the next item on the agenda, which is the reports from the committee chairs. I think we'll start off with Crick. Is there anything to bring from that?
Thank you. No, we've had an interesting meeting. I think the only thing in discussion that came up, I think the team are going to come back to Mary yourself on chair, the sort of renegotiating the environmental contracts in England and not necessarily thinking of UK. But that, as you know, it's one of the very common problems that we face. So it's just a matter of making sure that that's taken into account. But other than that, it's all there.
Any questions for Sean? No. Kate, I come to you next. Or Paul? Oh, maybe we can go to Nick. Sorry, put you on the spot, Nick. Anything that you want to highlight from the committee report?
I have a few things. Firstly, just to note that the work that assure yourselves around the NHS executive over the time is ensuring excellence again. Feel much more positive, both just in the content depth of insights we get and what that tells us, but actually the process is a lot much improved. We omitted from this report that actually we also saw the draft accounts for the year, which obviously still went through that final process, so we did see and consider them at the meeting, should be reported. The one other positive I wanted to put was obviously we noted that we had an audit of the duty of quality, which we put substantial assurance on. As you may remember, when we had the previous audit on the duty of candour, we had some assurance and we challenged that because we knew very early on. As we thought we had done some very good work in this organisation, and actually on reflection now, having looked at what else had happened across Wales, and the other work they've actually come back and agreed to upgrade that to substantial assurance given the context we had. So that was a very positive result, partly reflecting work obviously done in the organisation, but so happy to be able to think we did actually consider a challenge and came back with a positive outcome. So those are the things I'm trying.
So that's really impressive to challenge auditors to get them to change their mind. Yeah, well done on that. I think, are there any questions for Nick, firstly? I'm not seeing any questions or comments of Nick. I believe Kate's got some technical difficulties. So Neil, was there anything that you wanted to highlight on the meeting?
Just a couple of things. So very good conversations just around our kind of INTP and deliverables for the year. Lots of kind of challenge around that in terms of outcomes and what that means, and just continue kind of positive conversations and scrutiny around kind of risk appetite was wrapped in that space as well. So a couple of areas I think
that's really helpful, thank you. And really thank the committees for the work that they do on behalf of the board, because it enables them to have those deeper conversations that we can't hear and that we can't have here, and that gives assurance then to the whole board that matters being discussed fully, which is really helpful. So thank you very much for that. If everybody's happy, we've got a number of annual reports and work plans for 25. Annual reports for 24-25 and work plans for 25-26. So if I go to you, Paul, for that.
Thank you, Chair. Paul Basie, Board Secretary. So this small paper contains a huge amount of work that the team, predominantly led by Liz Penny, our Deputy Board Secretary, has conducted to give the board assurance that our committees are doing what they're supposed to do in terms of meeting assurance through to us as a board, that they did that for 24-25 through the annual reports, and that the board plan for 25-26 and the work plans set us up to achieve the same next year. So that's what these three reports seek to do. The annual reports for each of the committees have been around committees, so chairs and those committee members have been cited on them. And that's the same for the work plans, which take us to a new level of maturity in our assurance as we develop our cross-working programme, so that the committees are working together to build the assurance the board requires. And this is all built as well in terms of the improvement that we've got from the committee annual review of effectiveness, which we ran in January through to February, workshops and feedback. Again, the results of those effectiveness reviews have been reported to each of the committees and have been built into the programme of work, such as the high-level audit in QSIC on streamlining and improving processes is now being mapped across all the other committees with chairs and briefs. So these three items are here for assurance and statement questions.
Any questions?
Just one comment really, I suspect on behalf of all the chairs of the subcommittee, that thank you to you and Liz and the team, and actually this is a reflection of the work that you do in a year. It's so much, on one hand easier, we seem to get a lot more on the agenda, but one hand a lot easier and a lot clearer for us to track what we're doing and see what's happening, and the quality of what we have is down a huge part to you and the team behind you. It's really
Yeah, it's just that I think it's really strong. It's the strongest yet, as far as the presentation, the content. A really big thanks to Paul, Liz, and the team, and also it's really, I think we just still with progress, but getting stronger and stronger in showing the threading through of stuff that's covered in the board committees, how that interrelates with the board, how things are handled from the board into the committees, but also the strategic priorities. So it's just nice. It feels as if it's much more coherent than it has. So just a big thanks to both of the team.
Yes, a big thank you to Liz as well as all of the team. I think it is a huge amount of work, but it does enable us to actually see that we're doing what we're supposed to be doing, and it's all very well saying that we're doing what we're supposed to be doing, but seeing it on paper, I think is incredibly helpful. So it absolutely supports the work of the committees, which they couldn't be as effective as they are without this. So thank you very much. I think we can take assurance that we're looking forward to the next 12 months as well, and if nobody's expressed on their laurels either, which I think is really good because it demonstrates continuous improvement. So I think that's brilliant. Thank you very much for that. I think we move on to the next item on the agenda. Claire, it's the corporate risk register. If you want to bring any highlights to life.
First, yes, that's Claire Virtual, Director of Nursing Quality and Integrated Development. So the corporate risk register is here. It comes to the board twice a year. Normally comes with the strategic risk register, but we, as you know, we're doing more on that. So the collective sequence will marry back later in the year. I hope that you'll see from the cover paper and the risk register itself that the leadership team who lead this on behalf of vets and have the delegated authority around this does fantastic work through a number of their meetings and deep dives to get this into the state that it is in today. I think the paper's really clear in terms of where we are with the updates to the risk register. You'll be pleased to see in the actual risk register itself the same language that we're using in the SRR, risk caused by sultaning. So there are 11 current risks on the risk register. That's probably changed since we published this because it is a really dynamic register, which it should be because it is around our highest level operational risks, and we should have really agile mitigation. There are none de-escalated in this period, and there is one that's transitioned across to the SRO, or will be transitioning across to the SRO. I wasn't intending to go through each of them, but just for assurance, each of the execs that delegate this to their representative on leadership team are aware, cited on the risks, the detail within and the mitigation. Ones that I just wanted to bring to your attention, 1596, which Neil's team lead on, doing a deep dive on that in July, and we hope that one will come off because of the work that's being done around that more broadly across the work that Neil leads in his team. I wanted to also pick up 1678, which is under my area in terms of risk management, and the revised risk policy and procedure will make sure that we're really clear around how we report risks on datix. 1758 relates to an issue that Meng described to us earlier on, the issue with the Ratification Wales fans. So we're excited on that. And then just finally, 1531, which is the one which is transitioning across to the strategic with Brexit. So I'm happy to take on
Questions? I've just got one question really on 1614, which is just really to have a bit of an update on the hosting agreement.
Yes, so 1614 relates to the risk that our board won't be able to take sufficient assurance in the activities in the NHS executive. It is a risk that is out to target. The update in the paper is not fully up to date because things have moved on since this was prepared. You recall that the hosting agreement for 25-26 incorporated the assurance schedules for each schedule. As we haven't technically concluded that hosting agreement yet in terms of it being signed on and approved, that assurance schedule is not formally in place, but we are following it, and the NHS executive is complying with it. So the assurance that we're receiving is at the standard we would expect it to be. On the next paper, this risk will be updated to reflect that.
And I guess that was going to be my next question really, because it does lead into the next paper. But it's just a question of making sure that this is up to date information. So that's why I asked the question here. Are there any other questions about the corporate risk register? So I think it does reflect the amount of work that shows that you know, it's very dynamic. The fact that the executive continually reviewing this, which is, you know, makes it a living document and something that guides the way in which we work as an organisation. So I think it's really helpful, and it gives us, you know, an assurance that we're managing all of the risks within the organisation, not just those at the highest level. So thank you very much for that there. And you know, segues on very nicely onto you, Paul, with an update on the hosting agreement.
Thank you, Chair. So the hosting agreement for 25-26 isn't quite over the line. It's a source of frustration to us. But there may be some advantages to that as well. The reason why we've not quite managed to agree this year the hosting agreement is there's disparity in hosting levy in terms of what we proposed should be paid, which was the £815,000. It was in the paper from last time board, or the NHS exec feel they should be funding. So there's a slight disparity there that Neil has got action with large government team to clarify. Once that's sorted out, the agreement will go into place. However, on the recent MAG report, there are some changes to the NHS executive in terms of its name change from the 1st of June, and also some structural changes around its leadership structure as well, which we will need to reflect in the hosting agreement. So in terms of the timing for that, we will see what we can do. If we agree the hosting fee sooner than those changes come into place, then the hosting agreement will be finalised and approved, and then we'll just amend it and the changes follow. So that's where we are. It's a technicality. The relationship was working very well. The procedures in place, the assurances are flowing. So we would like to come, the updated hosting agreement also being in place, which is quite fair.
Thanks, Paul. Any questions on the hosting agreement for Paul? Really helpful update, thank you, Paul. I think, you know, it's just keep the board updated. Thank you. Okay, so next item on the agenda then, we've got standing orders and committee terms of reference. Paul, if you want to lead on this, please.
Thank you very much. So I've got all the exciting items today, as usual. There's a suite of documents with this paper, which are really, the government's really fresh. Our standing orders, we have to review them every year, that's the requirement. We usually review them in line with model standing orders that are issued by Welsh Government, but those standing orders have not yet been issued for this year. They were expected in April, but they haven't yet landed. So as you can see, I've done a review of the standing orders just to update some minor items which needed to be referred to, such as naming the cabinet secretary in the department correctly, and other updates which are orthographical and just typing on substantive. And then accompanying that are the terms of reference for each of the committees. These terms of reference have been through each of the committees one by one, and they're here for recommendation to the board adoption. Again, these have been updated to add in the NHS executive and the roles and functions around that, and also to add any updates that are required as a result of changes throughout the course of the year. So all these documents are here. I should flag that our standard financial instructions have been reviewed and do require a refresh because there's been some changes in procurement legislation that directly affect those SFIs. Again, we're waiting for model SFIs from the Welsh Government, so as soon as they're landed, we will be updated rather than doing a full update on our own and having to wind it back.
Thank you, it's very helpful. I'm assuming that everybody has read them and all the terms of reference have gone through the committees. Then, did you want to raise something?
Just a very minor point on page 3 and 4 of the pack talks about the line inserted in each of the committees, and it refers to NHS executive. Given the imminent change, I don't know whether it's worth changing that.
I think it may be sensible, and if the board's happy, that we put in a phrase which says the NHS executive then allows for a change of name with terminology rather than changing the name straight away. Does that work clearly?
Yeah, the registration committee will think to. Data needs, the data approval would be today.
But if we approve them on the 1st of June, we can put the new name of the NHS executive in, because the 1st of June is Sunday.
Is everybody happy to approve the terms of reference and the change as indicated by Paul? So we approve the 1st of June as they record the date 1st of June as the formal date of approval. Standing orders and committee terms of reference. Happy? Yes, I'm seeing nods. Okay, that's great. Next item on the agenda is back to Paul again.
Thank you very much. So yes, another suite of documents forming our governance framework here. We've got the Board Assurance Framework, which is now into its 2nd or 3rd full year this year. It's been updated just again to reflect changes throughout the year. No substantive changes have been made. So that one is here for approval with those amendments. We've also got the protocol for meetings held in private. Again, we're required to review this annually, and we do an analysis within the team of the types of papers that are coming to the private board just to assess whether that's appropriate, to see if there's any changes that we should be making. The result of that review is that we are within the scope of what's reasonable. As a board, we try and take as much in public as we can. That is something that we have done in last year and we'll do this year. So very few changes to make there. And then finally, the board etiquette policy has also been refreshed and reviewed as the board today, also for approval. No major changes.
That's great, thank you. Anybody got any questions for Paul? Okay, so we've got 3 documents to approve if people don't have. I've seen some nods already. So the Board Assurance Framework, the protocol for meetings in private, and the board etiquette. Take as a group. Are people happy to approve? Yeah, that's great. Thank you very much. We'll take those as approved. It's really good documents, and I have to say the board etiquette was one that I had not seen before I came here, and I think it's a really great thing. It reflects the culture of the organisation. So thanks for that. Okay, we move on to the next item on the agenda. Neil, this is the new people strategy.
Yeah, just a very brief overview from me. So yeah, I'm absolutely delighted to bring the strategy for 2025 to 2025 to forward today. This follows significant engagement in terms of this, and huge thanks to all the colleagues who've been heavily involved in terms of getting to this point. We've engaged significantly with our people, with our trade unions, the partnership forum, the DNC, also our staff network groups as well. This really does link to our long-term strategy. Really kind of sets out our vision for the next 10 years. There are some kind of big priorities in there but certainly for the feedback we've had from across the organisation in terms of our areas of focus, that they are absolutely right ones. A clear position and kind of next steps on this is hopefully following approval today. Clearly, we will do some work in terms of just making sure that this kind of looks and in kind of the right field from a kind of organisational perspective, and then it will be about delivering, making this happen, and have a clear plan for delivery against that. I've spoken to Kate, and again, thoughts are Podcom will be a kind of key vehicle in that space in terms of us kind of looking at progress, where we're at, but we obviously have a key IMTP deliverable now around the next steps and the actions which are in place to support the delivery of this. So yeah, I will pause that one, Chair, and we'll have to take any questions.
So thank you, Neil. And I know that quite a lot of members of the board have signed a draft and to input into this, which I think is, it's been really helpful. So are there any questions around this new people strategy?
Just a comment. Obviously, it's big thanks to the team who engaged a lot across the organisation. It may change the type, not in any material way, but as you said, with the kind of formatting, there may be some little tweaks there. But of course, an implementation plan is going to be key now, isn't it? So the strategy is sub-strategy, the strategy to support our long-term strategy. And so it's I guess the last time this was approved, it was in January 2020. And well, enough said really. So but that said, we've been implementing it anyway, haven't we? The core elements. So I think it's going to be important for us to develop not a 35-page plan that implementation plan that nobody really wants to read, but how do we do things in a kind of an agile way in converting this into an implementation? And of course, it could be of directorates, probably the kind of main show in town in many respects, but it's about all. We'll be tracking it as an exec team as well, and obviously we'll comment on board. So just to say that, really, that's really great stuff. It's really, really excellent. I'm not seeing any questions or comments. It's a great piece of work and really good that you've involved so many people in it. And I guess the planning of what happens next and the progress that goes through podcast and ultimately get the festival through ways. So that would be really helpful. So are people happy to approve this? There we go. We got formal approval for the people strategy until 2035. That's it. Next item on the agenda is capital programme, Angela.
Thank you, Chair. So the paper in front of you today is the 25-26, but capital plan is here today to seek approval of the discretionary capital allocation and our spending plan against that allocation, which is set out in table A. The paper also gives an update then on the strategic capital, which is within the three areas: the approved bids to date, which is in table B, the unapproved but proposed bids, which are set up in table C, and we touched on one of them earlier today, and also the status of the strategic position in terms of our capital as well, which is set up in table D, the strategic capital business case, sorry, it's table D. So I think the main focus for the board today is the approval of the spending plan, so we can push on and get our procurement in order so we can flatten that spending plan trajectory on capital. I'm going to try and bring it as much forward as we can, so we're not back loads into the final quarter, which you can see sort of that trend on the performance report that we can show in as well. So we're going to try and get that more on.
Any questions from anybody around this?
Obviously, a pretty rigorous process, hasn't it? Yes, we discussed it back to but we just pointed out there is a larger contingency that we hold in the normal. We normally hold 150k, roughly 10% of our allocation for urgent issues that we haven't planned for, which is any major replacements that happen. but we've held back 300,000 at this point in time because we have one of the areas that Mel mentioned earlier, like in the category 3, and being sustainability issue with one particular priority area that we need to resolve. So we're just working that through. So, but if we don't need that one, that will go back into the prioritisation.
It's really nice. It's really helpful to make sure that you've got something in your back pocket, isn't it? For that. So, and I'm right in thinking that the appendix just shows all of the bids that you received, whether they were approved or not approved. Okay, that's fine. Thank you. Just are there any other questions from people around the table? No? And people are happy to approve this as capital programme? Yeah, lots of nods around the table. Okay. Next item is the travel policy. And let's come to you as well.
Yes, Chair. So the travel policy is here today for approval. It's been through a lot of scrutiny. It's been an extensive piece of work. I know Selina and you've been heavily involved in this job. And it's here today for approval, as I say. It provides a lot of useful advice in there for staff and also opportunities for people to look at to consider more sustainable travel options if possible as well. So I think that really comes through in the policy. So as I say, it's here today for
Has anybody got any questions or comments on this policy?
I reiterated technically that I thought the kind of easy guide for people and the kind of steer towards more sustainable was really, I've not seen that before. It's really positive.
Yeah, very positive. I do have one comment, and it's I picked it up in the kind of taxi section, but it could apply more widely within the policy, and that's that there may be situations where people have to have transport outside the immediate policy because they need it for reasonable adjustments. And although it is highlighted right at the end of the policy that we have considered reasonable adjustments, I think taxis are probably the best example of where somebody might, not just because they're running late or have a heavy bag, might need to take a taxi for that reason. So I just wondered if we could put some amendments in the policy to reflect that. So subject to that, is there are people happy to approve this travel policy? That's great. It's a really good piece of work, and so you know, Samina and the team, whoever has contributed to this, I think it's quite far-reaching. That's the thing. So we've got the sustainable angle, but we've also got all of the kind of useful and helpful information within a policy which you know people are going to use. So thank you very much for that. And you've got approval. So next item on the agenda is the minutes and the action log from the last board meeting. Are people, or I don't know if there's anything that you want to highlight first of all on this.
Just looking to highlight from the minutes of the confirming an accurate record of the meeting, members 2 items for trade on the action log.
Okay, so let's go with minutes first. Is everybody happy that they are accurate? Yeah, seeing lots of nods, so we can accept that they are an accurate representation of what happened and the actions. If you'd like to take us through the actions, please.
Yes, there's 2 actions here post for closure. They are a little bit skewed in terms of gobbledygook. The item that's the version that's been put there. But the first action was an action in terms of staff sickness and the categories there. The action for that was to deal with it in the month when our update to be expand on that further today with Neil taking a even further action. And then there was an action, the second one for post foreclosure is the one in relation to inequalities data, whether any lessons learned can be factored in. And that's going to be considered also in the month on the agenda for today. So with that being incorporated in the inequalities section as post foreclosure.
People happy to approve the minutes and close those 2 actions? Great. Okay. Take that as approved. All next item on the agenda is also for you, ratification of chair's action and the common seal.
Yeah, so there's been no chair's action since the last board meeting, but we have applied the common seal once in relation to an underlease of floor 5 of Capital Quarter, this building, to the Commission for Tertiary Education and Research. So just seeking approval from the board for ratification of that seal.
We have approval.
No. Be sure. Conviction.
Thank you very much, everybody. Next item is the digital transformation audit year.
Yeah, so this one is, it's Audit Wales, agreed, I think it's 2 years ago, it's originally on our programme to do all health bodies in Wales audit and digital transformation. They're finally getting it up and running. They've sent us a project brief, which I will circulate around to board members. The aim is to have a self-assessment done, which has the opportunity for all board members to contribute to. And so we will make sure that you all have the opportunity to put your views and opinions in as part of this. The purpose of the paper really is a simple one, which is to delegate it down, given the timeline of this, to delegate the sign off down to Craig in 17th of June.
Questions for Ian? No questions for Ian. Okay, so I think that'd be helpful if you could circulate that by email, and I'm sure if Craig raises anything that they feel should come to the board, then that, you know, can come around the circle, as it were. So is everybody happy that we can delegate that responsibility to Craig? It's quite tight. It is quite a tight timeline. So if there is anything people want to comment by email, when the email lands on their doorstep, please can they respond properly, because that would be helpful to the team. Thank you very much for that, Ian. So we've got a few items to note at the end of the agenda. We've got the board forward plan. This is the chair's report from the private meeting, the last private meeting that was held on the 26th of March. Is everybody happy that that's an accurate copy? Yes, lovely, thank you. The board forward plan. Are there any questions? Claire?
Just to note that the corporate risk register is down for July, obviously it's come today, so we'll.
Right, okay, well, we can make a note of that. Liz, can you head a note of that? And as you said, the strategic risk register, and we'll get them all in line once they're finalised. So that might result in a slight change to this. Is there anything else on the forward work plan? So, and the 24-25 financial position. Angela?
Yeah, so this is just the month 12. The rest of what we've done is we put this on audit because we replaced it with the annual review. Yeah, so it just is the in month 12 position proposed to the what we discussed, which is probably a better one too.
Yeah. So are there any questions or comments about this at all for Angela? No, that's great, thank you. And similarly, same with the performance report for the month 12 again. So we've covered all that earlier, unless there's anything that people want to pick up additionally. No. And then the HEIW annual return for 26-27. Neil, is there anything that you want to pull out there?
You know, I think obviously in terms of return, we consulted widely on that in terms of what needed to be covered. Lots of feedback and additions from across the directorates, and that has been covered as part of the resume this year.
So it's just for information.
Yes.
Any questions for Neil? No, that's great. Thank you very much. I think that's all of those items for noting. So thank you very much, everybody. Diolch yn fawr iawn. And thank you for all of your questions. I think we've had some really great discussion today. So is there any other business from anybody? No other business. Date of the next meeting, everyone, is 31st of July 2025. still got 2024 in my head, definitely 2025. And so I will say thank you very much for attending, everybody, and see you again soon. Thank you.